that needed to happen. And because after that came out, you see all of these other European documents that came out afterwards. And maybe that was my role, was just to be the scapegoat maybe to get this rolling. But I think that in some ways it wasn't comfortable, but it needed to happen.
Thank you.
I'll go long answer.
All right, next up we have Grace Wilson from UC.
This is sort of about therapy, so hopefully our therapy physicists will come back on that here. I am a diagnostic imaging physicist at the University of Colorado Anschutz. I've been in that role for about 3 years now, and today I'm going to talk about not necessarily every physicist role in Y90, but just kind of my role and my experience running a Y90 radioembolization program over the last 3 years. So to start off, I have a few disclosures. I'm a consultant for Boston Sci as well as Murata Medical, specifically for their online platforms in both dose ordering and dosimetry. And my primary experience is with TheraSphere as opposed to SIR-spheres. The learning objectives for today's talk are just going to be understanding Y90 treatments. I'm sure most of us are pretty well aware, but I think it's good to have a nice reminder, especially for the trainees in the room. Then I'm going to talk about the Y90 program at University of Colorado Hospital. And lastly, I'm just going to kind of discuss physics support for Y90 in general, including useful metrics to track and helpful hints along the way. So Y90 radioembolization is also referred to as TARE or SIRT. TARE standing for transarterial radioembolization, SIRT standing for selective internal radiation therapy. It's kind of in this strange in-between space where it's not necessarily a brachytherapy, not necessarily a radiopharmaceutical therapy, but it involves taking radioactive microspheres and directly injecting them through the hepatic artery into targets in the liver. So those microspheres are going to embolize, meaning they're just going to stay wherever we inject them, and they're going to deliver radiation to our target, usually tumors that are of HCC's varieties. Most of these treatments are performed in interventional radiology departments. Whoever is in charge of the treatments, meaning whoever is the authorized user, is always up for debate for anybody who has a Y90 program. And the decision to treat these patients is multidisciplinary. At our institution, we have a very strong transplant team, liver transplant. So a majority of our patients are actually bridged to resection. And we work interventional radiology, medical oncology, radiation oncology, and hematology work all together to identify patients that would be good for this treatment. Okay. Y90 itself, or yttrium-90, is a radioactive isotope of yttrium that decays by a somewhat pure beta emission to stable zirconium. So once all of that Y90 is delivered to the patient, it just stays in that embolized area as stable zirconium and causes no issues. The energy of these beta particles is on average 0.93 mega electron volts, which means they travel 2.5 millimeters in tissue. And they have a max range in tissue of 11 millimeters, meaning that we can release patients same day for these treatments. Obviously, we're going to get a measurable signal outside of the patient just from Bremsstrahlung. However, it's not high enough that we have concerns for a patient's caregivers or anything along those lines. As I mentioned, the half-life of yttrium-90 is 64.1 hours or 2.67 days, meaning our 10 half-lives is about a month, and 94% of the radiation is delivered within the first 11 days of treatment. There are currently two widely used vendors for microspheres. There are a few more coming on, but these are the two that are FDA approved. TheraSphere or glass microspheres are going to be primarily used these days. They were first, I guess, like FDA pre-market approved in 2021 for 1 to 8 centimeter HCCs or hepatocellular carcinomas. Many people use both TheraSphere and SIR-sphere off-label though for all sorts of different disease states. However, primarily everything is used in the liver. TheraSpheres are 15 to 35 micrometers in diameter, and they have a pretty high specific activity per sphere, around 4,000 becquerel per sphere at calibration. And the way that we order TheraSpheres in particular is via a unit dose. So we don't have to draw anything up in nuclear medicine. We just figure out when the patient's going to be in for the treatment, when we think we're going to administer, and then just order dose based upon that. I have a prop. because this is an afternoon talk and everyone's exhausted. So this is going to be what you kind of see in the photo there. It's just a lead pig that was used for a previous treatment. There is no radiation. Do not worry. That'll be hilarious about that. Everybody should post it on the listserv. And then here is just a mock TheraSphere vial that we would use whenever we're training a technologist. A real TheraSphere vial will have the same information as you see here on the lead pig. And then also you'll note that this little TheraSphere vial will look different from this. There's browning due to the beta radiation damaging the glass. So pass it around, don't lose the plug. Pretty please, thank you so much. And then I'll know you're asleep if I hear a big lead thump on the table. So as I mentioned, I primarily work with TheraSpheres, but SurSpheres have also been around for a very long time, even since the 1980s. SurSphere was actually the first radioactive microsphere to gain FDA pre-market approval in 2002. And that was only for unresectable metastatic colorectal cancers. However, they recently got their FDA pre-market approval for HCCs in 2025. These are pretty similar in size. There are some downsides to resin microspheres, including leaching, stasis, things along those lines, and they have a lower specific activity, which is why a lot of physicians are turning closer to these glass microspheres. However, you have some benefits of SurSpheres in that you can kind of draw them up in nuclear medicine the day of the treatment to ensure maybe like a more personalized dose to your patient. The clinical process for a patient undergoing a Y90 treatment is kind of the following on the left. So first we have our clinical evaluation of our patients, but as I mentioned, that usually takes place in tumor boards. Patient eligibility depends on a variety of criteria, but generally they have to be in pretty good standing with ECOG scores of less than 2. As I mentioned, a majority of our patients are going to be bridged to resection, and here's an example of imaging for a patient on a diagnostic MR. You can see that nice juicy segment 8 hepatocellular carcinoma there. So this was a patient who is perfect for this treatment, where they can just go in through the hepatic artery directly to that segment 8 and inject the microspheres into that tumor. Then the patient will come into the interventional radiology suite for a mapping. This is what we call our angiographic mapping day, where essentially the IR will go in, kind of figure out if there's any variant anatomy that we would be worried about, maybe look into the gastric artery falciform and try to figure out where we want to deliver. Sometimes tumors have multiple arteries that would be feeding into them. However, this one looks like we have a pretty strong segment 8 artery feeding directly into that tumor on that DSA. A lot of my physicians will also use CBCT in the interventional radiology suite, and that will also confirm, that we're treating exactly where we want to treat. Another thing of note when it comes to Y90 is the liver is very unique in its blood supply. I just want to mention this. So I keep on talking about the hepatic artery. The hepatic artery is obviously our nice oxygenated blood. And that is why we essentially are going to inject the microspheres into there, because there's preferential uptake of oxygenated blood in the tumor as compared to the portal vein supplying the rest of the liver with healthy blood. So these treatments work really well for these patients because the rest of their hepatic reserve is pretty safe because they have that portal vein supply. At the end of mapping day, once the IR physician is satisfied and figured out what they want to do for the treatment itself, they will inject the patient with anywhere from 1 to 3 millicuries of TIC99 MAA. And that is how we calculate our lung shunt fraction, just in case there's any sort of pulmonary shunting. In SurSpheres, if you have a lung shunt fraction greater than 20%, it's a contraindication for treatment. In TheraSpheres, we just want to make sure our lung shunt is going to result in a dose less than 30 Gray to the lungs per treatment, less than 50 Gray to the lungs lifetime. I've seen lung shunt fractions anywhere from 2% up to 60%. So definitely depends on your patient. And there are instances where you can have a lung shunt fraction of 60% and still treat, especially with TheraSphere. And then the actual treatment day itself is going to look somewhat similar to the patient, but very different to everybody else involved who understands radiation safety risk. The treatment day is going to usually be up in IR as well. Once they get access to the patient, they set up this very complex administration kit and box. Inside the middle of the box is where you will see this lead pig with that dose in there, and they will administer through a series of, tubes, syringes, all that kind of good stuff. And this box is just to ensure that the exposure to those in the room is minimized and that we can get the dose to that tumor as quickly and easily as possible. Fortunately, in the Y90 process, a patient is injected with imageable radionuclides twice. First, during the mapping. So during the mapping with that technetium, we actually obtain a SPECT CT as well as a whole body planar, both for the lung shunt fraction, but also so we can do treatment planning. Tech MAA is not a perfect substitute for Y90 in many, many ways, but it allows us to have an idea of kind of what some of our uptake in our tumors is. And then Y90 microspheres are imageable via SPECT and PET, which is very unique. SPECT, we use Bremsstrahlung imaging from the beta particles interacting with the tissues in the patient. And PET, we have a 1 in 32 million chance for positron emission. So it takes a little bit, but you can still get a sufficient image. And here I have a slide of that patient having a successful administration to that segment. Y90 dosimetry is constantly improving over time. A majority of sites will use something called single compartment dosimetry, where they assume a uniform activity distribution to a whole compartment. That's usually going to be your treatment compartment, your lobe, your segment, etc. Obviously, this is not realistically the case, but it's how we order doses, and it's how our IR physicians are going to, or any of our physicians who order dose, understand your dosing for your target. Multi-compartment dosimetry is essentially just, instead of saying, here's our perfused volume or our target volume, they say, here's your target volume, here's your tumor volume, here's your normal tissue volume. And they use tumor to normal ratios, either from contrast enhanced imaging or from uptake imaging inspector PET to treatment plan based off of that. And that provides an average dose to each compartment. And lastly, there's voxelized dosimetry, which is what a lot of folks are going toward in the future. Voxelized dosimetry is exactly as it sounds. You have voxels that have, not necessarily uptake, but activity distribution, either from your MAA or your Y90. You can use SPECT or PET, especially for the Y90, obviously. And that allows us to have dose distributions to, whatever you inject radionuclides into. And it also allows our physicians to use dose volume histograms for planning purposes. So for TheraSphere, and particularly at our site, our goal is to induce tumoricidal effects. And in most Y90 treatments, more is better because over time, we've only kind of started with pretty generic dosing of 120 gray to a lobe. But now that we're getting more into segmentectomies and more personalized dosimetry, we've realized that we need to kind of increase the dose to the tumor to the best of our ability. A few things that are limiting us are the dose to normal tissue and any sort of compromised liver, which I have listed up there, as well as our lung dose. Most recent Y90 medical events have been a lot about GI deposition as well. GI deposition is a contraindication for most patients, but sometimes accidents happen day of. The liver's pretty unpredictable, as is vasculature, and sometimes Y90 can end up in the GI tract. So it's another reason for post-treatment imaging, if you are ever concerned about that. The activity required is based upon a pretty simple equation. Obviously, it's different for TheraSphere versus SIRSphere, but assuming a uniform uptake, all you need to calculate the activity required is your desired dose to the perfused volume, as well as your mass of the perfused volume, which we assume a liver density of 1.06 grams per cc. At our site, and most sites nowadays that have a lot of interventional radiologists doing a lot of treatments, we aim for a lobar dose of 120 to 150 gray, and that's to the whole lobe, or a segmental dose of 200 to 600 gray. And I was told by radiation therapy people that, wow, that's really high. I don't know. When it comes to regulations, Y90 is going to be pretty similar to all of our other therapies. Our imaging people will be like, what's a written directive? And that's kind of what makes me a unicorn is I understand what a written directive is and how to respond to a medical event. So a written directive is required because this is a therapeutic dosage of radioactive materials. It requires the patient's name of the radioactive drug, prescribed dosage, usually activity in this case, the route of administration, AU's name and signature and date. And then a medical event in Y90 usually looks like the total activity delivered to an organ or tissue, in this case our target, will differ than what is prescribed by 20% or more, and that's the activity that we had prescribed to the patient. It's okay to change your written directive right before you treat, but you cannot change it after. So I get physicians calling me all the time being like, hey, the dose came in a little cold or something along those lines. And in that case, we would just update the written directive. The usual special suspects are also a medical event. So wrong patient, wrong site, wrong route. We have not had that occur yet. And if there's any sort of major spill with Y90, it's not just a major spill from a radiation safety perspective. It would also likely result in a medical event if some dose even got to that target. So what's super unique about Colorado, and I want to say like Illinois is the other state, is we have authorized users, pretty standard procedure. They prescribe dosage, direct the administration, and prepare to administer the dosage itself. But we also have authorized medical physicists. So who in this room is an authorized medical physicist? Deep, 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 deep. And who in this room, keep your hands up, is an authorized medical physicist for Y90? Probably just one, two, fabulous. Love it. Very unique position to be in because it is kind of, any sort of physicist could be in this position if they end up doing Y90. Our therapy physicists are much more familiar with what an AMP does, as are the regulations in Colorado. These are the 4 things that are the duties required of an authorized medical physicist, and they don't super duper apply to Y90. So a lot of us AMPs for Y90 are left with, well, I guess I'll just do all of it. Just because we want to make sure the process is safe and efficacious for our patients. Who can become a Y90 AMP? You can do certification by an NRC recognized specialty board, which I believe used to include diagnostic ABR, but has changed since 2023. The route I went through was the not even long and tortuous, just kind of annoying route of doing a master's or doctorate in physics, a full-time year of training in medical physics, a full-time year of work experience in Y90 or RAM, the vendor training, and preceptor attestation. And that's how a Y90 AMP is born. Who should be a Y90 AMP is obviously up for discussion. And it is my experience, in my opinion, that the necessary skills for Y90 are working with RAM, familiarity with regulations, and an understanding of dosimetry, at least a baseline understanding of dosimetry, especially MERD dosimetry. Who qualifies? Technically, diagnostic imaging physicist. Could be helpful to have a diagnostic imaging physicist do it because I'm already in IR doing IR stuff. So having one point of contact is helpful for the clinical team. Radiation therapy physicist. You guys are usually already AMPs. It's just another checkbox on your license, and you have much more familiarity with therapy as opposed to a diagnostic physicist. Nuclear medicine physicists, they have more experience working with RAM and more experience with MERD dosimetry. There's an argument there. And radiation safety or health physicist, this is actually what we usually see around the rest of the country. So most of the time it's a radiation safety officer following the dose from dose in to waste out. But regardless of who this ends up being, the physicist always has something to offer, at least in my experience over the last few years. So there's so many screens in here. Okay, so our approach to Y90, and this is our program that we support both at the University of Colorado Hospital and Highlands Ranch Hospital. We have one current vendor. We used to have SurSpheres as well. However, I believe we ceased using them about 6 years ago due to physician preference. We also do a single type of like dosimetry and administration, meaning like we don't have like different physicians doing things differently. There's one checklist for TheraSphere, and that's all there is. We serve 2 sites, as I mentioned, a large academic hospital where there's many AUs, as well as a smaller hospital where there's 1 AU. I'm only going to be talking about the large academic hospital. The smaller hospital is much closer to what normal AMPs will be dealing with. We do 100 to 150 cases annually of all types. Lobar, segs, multi-segs, combinations. We have a lot of different intents as well. I would say that a good portion of our patients are going to be bridged to resection, and we have all sorts of diagnoses, so HCCs, ICCs, and metastatic. Usually, if it mets, they're neuroendocrine mets. We do repeat patients as well. We have 8 to 10 AUs at any time. And that sometimes becomes complicated, but because we have such a strong system, everyone's doing mostly the same thing. All of our authorized users are physicians in interventional radiology, meaning they are the ones who do the mapping, they do the treatment, they order the dose, so it is run by them. And we have 2 to 4 AMPs at any time. Usually this is going to be a diagnostic or a nuclear medicine physicist in radiology. And we do things like check the dose, prepare case date paperwork, support the case day of, and calculate the dose delivered. So our standard procedure at University of Colorado Hospital is as follows. The patient is selected for treatment about 6 weeks beforehand. The schedulers confirmed physicist availability because they already have the AU schedule. The AU has to be there. But we have a very strict, you have to make sure a physicist will be available. This is going to become a little bit less complicated once we get more physicists on board. Currently, it's myself and Mike Solosky. So we do. The IR authorized user will perform a mapping in MAA 2 weeks out, and then they will send the physicist the dose order, and we will just make sure everything looks good. The case day itself, the authorized medical physicist will prep all the paperwork, and we will be on site and ready to furnish assistance at any available moment. The dose is sent to nukes. They open it the morning of the case. They assay it the morning of the case. And it is secured in nuclear medicine until an IR technologist will come down and pick it up. Our IR technologists are going to be the ones setting up the administration box, putting the dose in, and then the IR technologist will get the approval from the authorized user to not spike the dose, but to essentially, if anybody's done a Therasphere treatment, attach the dose to the dose delivery system. Once they have reached their desired target, the IR authorized user will finally spike the dose and push those needles down. If anybody else is familiar with this, you have about an hour until that dose goes bad, according to the United States Pharmacopoeia. So we always wait until they're fully ready to administer for that. And then we administer dose to the patient. The IR technologist is the one who does the Geiger counter survey, gathers the waste and brings it down to nuclear medicine. Nuke MedTech measures the waste, lets us know when it's ready, and physics calculates the dose delivered. So a lot of people say, okay, so then you do nothing all day, which is fair. I mostly sit in my office because whenever I'm there for a case, it stresses some physicians out. I'm trying to remedy that with snacks and it's not working great. But we are there to provide support for every step of the process. Nuclear medicine just this week, call me, we're missing a dose. So that is our job, to essentially track down that dose, both with the vendor, with the mail carrier, make sure it gets there on time. The dose came in too hot, too cold, super common occurrence. They just have to make sure they call us and let us know, and then we will coordinate with the performing physician to see if they want to change the written directive. The authorized user always calls and wants to change the written directive. As long as they don't deliver, I'm happy with that. I've also gotten calls much more related to something that could be a spill or a medical event where they're saying the syringe won't budge. And I'm like, I don't know how syringes work, so I hope everything's okay. And then I just go in person to provide that support if need be. The IR techs will call me if numbers are weird, or if they think that there's going to be contamination, because if they think there is, there already is. They want to break things easier to me. And then we always get a call from PET-MR. At our institution, all of our patients get post-treatment PET-MR unless they're contraindicated or unless they're part of a clinical trial. And usually it's just like, where's the paperwork? Where's the paperwork? Where's the paperwork? 9 times out of 10. My role is very unique in that I am 40% Y90, 40% fluoroscopy, and 20% fitting everything else that I do into my day. I'm 80% clinical and 20% academic, and I also try to split that up between Y90 and fluoroscopy. So the clinical Y90 tasks that I do are dosimetry and dose ordering. So I am our local resident expert on Simplicity's dosimetry platform, both for single, multi, and voxelized dosimetry. So I teach the physicians how to use it, and I will provide additional support if they're like, hey, I want to get a D95 to this tumor. How do I do that? Because a lot of IR physicians will have never seen a dose volume histogram in their life. Case day support, as I mentioned, I'm getting calls about that. Medical event investigation, huge part of the Y90 physicist job. And lastly, additional program initiatives. Just last week, we all of a sudden were told that how we order dose is completely going to be changing, and that it's not going to be changing. It has changed, and we were given no warning. So I have to implement that, make sure everybody's on board and knows what we're doing and how to do it. Whenever there's a change, like the United States Pharmacopoeia, like with the spiking situation, I had to make sure that's implemented and that we're not going to get audited or in trouble with that. Or if there's something silly like nuclear medicine is upset because the MAA administrations, the physicians just like throw the needle back into the pig and then throw the syringe back into the pig, and then there's contamination everywhere and they can't measure anything. Weirdly enough, that's the physicist's job to fix. And so I had to make a helpful diagram to teach IR physicians who have been trained for years and years and years how to reattach a needle to a syringe. And that took once. Yeah, and also just double checking everything. It's really, really important to make sure that there's one person overseeing the whole process because it's easy to miss steps. And I think that's a huge clinical value of a Y90 physicist. Teaching Y90, I'm very proud. We started a technologist training program, and also I run Geiger counter trainings for every new technologist or even traveler who comes in, just to make sure that they know exactly how to use a Geiger counter and that they're comfortable using it to do contamination surveys. And the lead tech and I have a very strong relationship where she actually proctors them for 5 or 6 cases. She has a vendor proctor them for a case, and then she has me proctor them for a case. This has been massively successful, and our audits have resulted in like nothing over the last few months, which like feels really good at radiation safety committee meetings for me. I also do things like in-services all the time, especially for like pregnant patients or not pregnant patients, pregnant workers who have a lot of concerns being around Y90. I've created educational pamphlets for them as well. And then I work a lot with med students, residents, fellows, trainees, and soon to be diagnostic physics residents. And my therapy physics residents. And lastly, I do research, mostly clinical research and clinical trial support. I'm pleased to say that we just treated our first patient for Y90 of the kidney yesterday, and it went very well. We provide support in the logistics, the safety, the dosimetry, and the imaging for a lot of our trials because we're kind of the local and national experts on the matter. I do clinical driven projects. Mostly in interesting cases like, complete pathological necrosis, like what our dose limit for that is, or like in this example paper, hypovascular tumors and the success of Y90 in hypovascular tumors. My only piece of advice on that is make sure you have a physician champion because you do not have the background entirely to understand the full field of interventional radiology. And then we sometimes do some physics projects. I know I'm almost out of time, but I just have some really quick lessons learned and helpful tips. I can't believe you made it into 3 people's presentations, Mike. That's like hilarious. I didn't know you were so photogenic. Metrics to track. I'm a data freak, and I'm sure most of the people in this room are. Track every metric you can because owning that data and analyzing that data is good for everybody. It's good for logistics, it's good for medical event investigation, it's good for research, and it's especially good for when you get a call and say, hey, my patient's, surface dose is reading 40 MR per hour, is that normal? If you have all this data and you have data over a long period of time, you can kind of let them know if it is normal or not, and not have to look into it and do a huge investigation. So I highly recommend if you are running a Y90 program or any sort of radiopharmaceutical therapy program, learning how to code or doing everything like in Excel so you can parse through that data really quickly. Here's an example of some of the data I have. This is percent dose delivered over time. Our limits are 80 to 120%, so anything falling below that is going to be our medical event. This lets us know, and I could split it up by authorized user, I could split it up by treatment type, everything like that. It just lets us know how on track we are. We also have lung shunt fraction over time. Here's that 60% lung shunt fraction I was talking about. Patients still got treated. But this also lets us know like, hey, lung shunt fractions are getting kind of weird. Can you look into that? Having that data means, you're going to have years and years of information backing you up if a problem does occur. Residual waste is also a good one. So percent residual waste, we set to our site at like 2%. Some AUs will have higher residual waste than others. And you could go in and investigate it all you want. This kind of information is super helpful for medical events. And lastly, just my final example is whenever nuclear medicine is kind of doing their exposure rate measurements, kind of knowing what to expect from those to ensure that our calculations after the fact are accurate. I found that from GBQ to MR per hour, it's around like, if you have like 1 GBQ that they're assaying in the dose calibrator, it's like 3 to 4 times that for your MR per hour exposure rate measurements. So if they're sending me paperwork this is all fake paperwork, by the way. I guess I should say that. If they're sending me measurements that are like, oh, I measured 1 MR per hour, that's incorrect. And that's you on the physicist to make sure that that is corrected in not just like the patient's record, but in your calculations too. And just to wrap up, I have 4 little tips. 1, be familiar with liver anatomy. Our radiation oncology colleagues are laughing at me right now, but a lot of physicists, like diagnostic imaging physicists, we cover every modality, we cover every body part. We cannot learn all of the anatomy for every single type of case. But if you're going to be a Y90 physicist, I highly recommend learning liver anatomy in order to speak with the physicians in a meaningful manner, and learning it as well on interventional imaging is very helpful. Being familiar with clinical trials, these are going to be what our physicians are dosing off of. And if your physicians are not dosing off of these, you could bring that into your practice. I highly recommend it. They're updating information all the time, especially personalized dosimetry information. And I put some of the Dososphere, Legacy, Razor, Target, as well as the Global Steering Committee guidelines. Identify existing structures, including procedures and practices. Go to all of your AU's cases. If you haven't already, some of them will just draw blood for no reason. They'll inject the Y90, then they'll draw blood, and you're going to be like, what the heck is that about? Especially if you have to do a medical event investigation and you open up the thing and there's blood everywhere. Opportunities for improvement. Like, don't immediately go and suggest something. Definitely give it some time, but identify those opportunities, and importantly, identify key players and the allies that you have. Staying firm on radiation safety, but also try to think of things from everybody else's perspective. Not everyone in the clinic has all the time in the world to focus on the things you're focusing on. So just do your job as a physicist and try to focus on the numbers while everyone else is doing everything else. And lastly, recognize your value. As I mentioned, the Y90 physicist is the only person overseeing the whole process. I think it's immensely, immensely important to have somebody in that role. And radiation safety doesn't always have the time. You always have something to offer, whether that be dosimetry, education, safety, but most importantly, especially for those doing the procedures and the patients in the procedures, peace of mind. And I think that was it. Thank you to my team for putting together a wonderful Y90 program and for offering me my dream job. Thank you.
Thank you. Any questions?
Sorry, I went long.
Grace, that was great. That was a wonderful talk. What percentage of patients are you guys doing voxelized dosimetry for currently?
I think
only for segmentectomies or retreats?
I think it just depends on the AU. We're currently working to standardize our practices. So we have some AUs who will use voxelized dosimetry for every patient, especially if we have patients who have like a bunch of tumors that we're all trying to target at once. Most of my AUs will just use voxelized dosimetry to get the D95 of small to medium sized tumor. And I think that's probably the best use case. Voxelized dosimetry is also useful if you have really large tumors with hot spots and cold spots.
That's good. Thank you.
Be around. Feel free to ask me. Where's my dose? Make it. Woo!
Thank you. Thank you.